So, as custom says, I'm Sarah Holmes. I'm Medical Director for Marie Curie. I think as we're running a little bit late, I'm not going to give any spiel. I'm going to get on to the most important matters in hand. This next session is a practical session about how you can bring what matters most conversations into your real life practice. So I'm going to hand straight over to Karen Turner, who's a Senior Improvement Advisor at the Royal Free Hospital in London, who's going to share some tips with us. Thanks, Karen.
Hi, thank you so much, Sarah. I'm hoping everyone can see my screen. Hello, so yes, my name's Karen Turner. I'm what's called a Senior Improvement Advisor at the Royal Free Hospital. And that basically means I work with teams in the hospital to either improve patient or staff experience generally. And I'm going to just tell you about my What Matters to You story. And I work in quality improvement, so I'm going to share stories and data, because those of us who work in improvement like both stories and data I'm going to share with you over for the next 30 minutes or so. So I want to show you where it all started for me. So before I did this role, I was working as a physio. I've been a physio in practice for about 20 years, mostly in palliative care. And I was working 2 days a week as a physio. I was working here at the Royal Free, where I am today, and at Marie Curie Hospice in Hampstead, which is just a 5-minute walk up the road. And I happened to be on a Florence Nightingale scholarship at the time. And part of that was taking new experiences and doing things that you wouldn't normally do. So I took the opportunity to go to the IHI, the Institute of Healthcare Improvement International Forum. And this happened in London 2017. I was really nervous. I felt I had massive imposter syndrome. You can see the group of us here that went from the Royal Free, lots of very senior people and me, and I felt like a bit of a fish out of water. And we had 2 days or 3 days of different speakers. It was all face to face in those days, which was wonderful. And there was so much I heard. And so much that sort of wowed my brain, so much inspired me. But at the end of the 3 days, James Mountford, who is our Director of Quality Improvement, pulled us all aside and said, "What's your take home? What do you think you can take home from this conference?" And I'd heard people speaking about what matters to you and the work that Maureen had done, and there had already been an international What Matters to You Day the year before, in 2016. 10 countries had been involved, and the movement was just starting. So sort of Chris said, I sort of wanted to become a follower of this What Matters to You movement. So I said, why don't we have a What Matters to You day at the Royal Free? I felt really embarrassed saying it, thinking, gosh, who am I to suggest something like this? But James took that on, and we organised What Matters to You Day. And I was working in therapy at the time, so I thought I'll just do it within the therapy team. And for me, What Matters to You was, I heard it. It was a really good take home as far as I was concerned. It was something I could practical, doable. I could test it. And if you were to ask me then, I would have definitely said that I thought I was already doing it. That I thought I was already offering patient-centred care. So I thought, okay, well, that's good. I'll sort of test whether I am or not. So before we ran our What Matters to You Day, I did a sort of small test of my own. I was working at the Marie Curie Hospice, and I went onto one of the wards, and I had 4 What Matters to You conversations that afternoon. The first gentleman, and all patients I knew, and all patients that I would have thought I knew what mattered to them. The first gentleman I went to go and speak to, I said, "What matters to you?" And he said, "When I go home, I want to sit in the garden with the sun on my face." I thought, I knew you wanted to go home. I didn't know that bit about the sun on your face. And it did mean that made me think, oh, right, well, I need to make sure we can get you a wheelchair. And how do you have access to your garden? Is that possible? And it wasn't. And we had to work towards that. The next person I spoke to said, what matters to me most is having smiling staff come into the room. And I thought, oh, well, I know about you and your movement and how you move up and down the stairs or get out on and out of bed, or how strong you are, but I didn't know that really mattered. And what an easy, sort of straightforward thing that we could do to make sure that we're always smiling when we come into the room. The next person I spoke to said there was too much going on in the ward. They wanted peace and quiet. They were too busy, and they felt really, really hassled. And what mattered to them is they were left in peace. And I thought, okay, I didn't know that about you either. And the fourth person I spoke to said, I'm really lonely. I don't have really hardly any visitors, and I sit here or lie here staring at blank walls, and I'd really love someone to come and talk to me. So after that afternoon of asking people what mattered, I thought maybe I wasn't as patient focused as I thought I was, and I hadn't really seen the patient as a whole person. So that I thought, okay, this is really worth testing. And the conference that I'd been at was just 5 weeks before the first, before What Matters to You 17. It generally happens in about June every year. And so I joined in for the next What Matters to You day that had been organised by Anders, who I think is on the call today, from Norway, and he'd started the days, and they were adopted as well in Scotland. So it was very early days. And here's a picture here of some of our What Matters to You days, not just that day, but the other ones we've had. And I worked with a colleague called Bernadette, and she was in Barnet Hospital. And what we asked is, we said, just really practically, we asked every therapist to ask one patient, what matters to you, and record what they said. So I thought that was quite doable. So we did a presentation to the therapy department, and we said, please ask one patient. But what we did do, and we got this from the Scottish website actually, was that we asked staff at the same time to reflect on that experience. And that was really, really key for helping us to learn more about this really important what matters to you question. So this is what we found out in 2017, what mattered to patients. We sort of aggregated the results and put it into this word cloud, as you can see. You know, and people care about having excellent care, and the staff who care, and getting home, and the ward environment. And so this was 200 conversations, and you can see they fit into different themes. And this is what we found out what mattered. And I wonder if you're looking at this thinking, I could have guessed those things. I could have guessed these things matter. Is it really important to ask the question? But I guess what we learned on that day is you don't know who these things mattered to. You don't know who wanted better food, or a cup of tea, or to go home or not to go home. We don't know that. So we learned that actually aggregating data is important and interesting, but what we mustn't do is stand too far away from the sort of the conversation, the what matters to you conversation. And what happened when we looked at staff responses, we learned so much. So this is what staff said, the impact of asking what matters had on them. And you can see lots of quotes here. You know, one of the therapists said, we shouldn't go to see a patient with our own assumptions about what matters to them. And I totally echoed that, totally understand that, having had my own experience. It helped get to know a patient better. It gave, asking what matters to you gave a patient, confidence about talking about other issues, not just about therapy related issues. It's a really, I sometimes talk about what matters to you as a key. It's a really useful, brilliant key to be able to unlock a door into a really beneficial, powerful conversations. It's 4 words, what matters to you, and yet it's so powerful. So we learned a lot about what happened, what staff said, and I think in summary, our main learnings from that day were you can't guess what matters, and we heard that over and over again. Information needs to be shared. Sometimes they need to be shared because someone else needs to action it, and sometimes it needs to be shared because sometimes it's hard to carry and hear that information, and sometimes it needs to be discussed at a multidisciplinary team meeting. We learned that it enhances conversations, but it's not always easy to ask what matters to you. Some people that said to us, I went and asked a patient what mattered to them, and they sort of looked at me in a sort of a strange way. And so I changed the conversation around and I said, oh, what's important to you today? Or how can I support you? Or is there anything else you'd like to know? So we learned about other questions that were useful to ask. We learned that actually morale at work that day just shot up. People loved being involved. And what they also reported on doing is changing practice, doing something different as a result. One of the biggest things that came through was that little things can make a really massive difference to people, and that the other thing that we learned is that what matters can change. So what matters today will be different to maybe what matters tomorrow. So asking regularly is really important. And at the end of this, I was thinking, oh my goodness, how do we actually make, how do we ask what matters to you as part of normal practice, because it seems to be really important and a really important question to ask. So this is what we trialed. As part of the scholarship, I had to do a project. I actually was halfway through. I was fairly near the end of a project I was doing, and I basically ripped it up and thought, no, this is what I want to do. I spoke to my supervisor and she said, I can hear the passion in your voice about what matters to you. Do it, change it and do something different. So what we did was we had this form here that you can see, which had different questions that had come up from the What Matters to You Day, different things to ask patients. And then we had this amazing team at Marie Curie Hospice in Hampstead, and no one had ever heard of What Matters to You before. And we started with this form. We used to just call it the form. And we started with one patient on one day. And then what we did was we brought this form that had been completed into the multidisciplinary team meeting, and the patient was discussed, and then actually what mattered to them was also discussed, and people could like sat up in the chairs and went, oh really, I didn't know that. But it grew, and people were really keen for it to expand. So it went from 1 patient 1 week to 3 patients to 5 patients to the whole ward to the other ward, and very soon we were using this for everybody. And I remember going to sitting in an MDT once, and I remember asking the team, how are the forms, the What Matters to You forms, how are they going? And one of the registrars said to me, oh, do you know what, it's yeah, they're great, but, and I thought, oh dear, here we go. And he said, what happens is we discuss the patient in the way that we would. So say Mr. Biggs, he's got prostate cancer with metastatic disease in his spine and his in his legs, he's got a lot of pain, and he's sitting in the chair most of the time. And he said, what happens is we discuss the patient and all the things we think we need to do, and then we hear about what matters. And we hear that his name is Jeff, and that Jeff, what matters to him is that he wants to go home to be with his dog because he's worried about his dog. And so our whole conversation is then around, well, how can we get Jeff home to be with his dog? And he said, what we really need to do is discuss this at the beginning of the MDT. So, and that's what happened. They started introducing the patient by saying what mattered to them, and it made a really, really big difference. And this is just some of the things that we learned in the early days. You can read these things here. And I do look at this list sometimes and think, what answers here wouldn't have come up, or would have come up on a normal nursing, medical, OT, physio, dietetic assessment? When do we give permission or opportunity to say what really matters to someone? Are we just interested in sort of what matters to us when we go to carry out our assessment? And maybe we need to be thinking about seeing the person as a whole. And I think the what matters to you question does that, I mean, really, really well. But I mean, over and over again, we hear it's really, really hard to get it to stick, asking what matters. I mean, there's loads of people on this call, and I'm sure many of you have had the same experience as me. You know, you really want to ask what matters, but have we got the time? So people are really, really worried about that. They're also worried about opening a can of worms. Oh my goodness, what happens if I ask? What am I going to hear? People think maybe it's not relevant to me. Maybe it's not really relevant to the job that I've come to do. What matters to you maybe is for somebody else. And people think, you know, what happens if I can't do what matters? And I have to say that with what matters to you, there are 3 really important things, as you'll know, that go alongside what matters to you. You have to ask what matters, and that's really important, how we ask and how we do that. We have to listen to what matters, and we have to do what matters. And there are 3 really important components that go with what matters to you. And there is a lot of worry about what happens if I can't do what matters to someone. And then there's people like me who thought, do you know what, I'm already doing patient-centered care. I've been doing this a long time. I've been doing this 20 years. And I'm not sure if I need the question. So these are things that I've heard, and they're all valid. They're all things that I've thought about as well myself. But what we've done at the Royal Free is we've done quite a lot of work in thinking about some of these issues, and we've collected quite a lot of data over the last 5 years and about our What Matters to You conversations. So out of 5 years of collecting What Matters to You data, or what matters to you, what conversations we've been collecting, these are the figures that we found. So we see that a huge number, so 60 to 70%, so over like 2/3 of people, of staff, say they change practice as a result of doing what matters, of asking what matters, sorry. So they 70 to 80% learn something new. So they learned something they didn't know already about the patient. Like me, when I walked around those 4 patients on the ward when I first heard about what matters to you, and 80 to 90% of staff report it enhances the conversation they have or the connection with the patient. They're phenomenal, phenomenal numbers, and they've been very, very stable since we've been doing this for the last 5 years. And so I think when I look at these figures, I kind of think, can we afford really not to be asking what matters? And when I look at them also, I kind of think this is, in some ways this is great data, but it's really sad that we don't have this this information about our patients, that it's not so inbuilt in our systems and in the way that we do things, that we know this straight away. It's not part of our normal assessments. So so I think this is really important and interesting data. The other thing that happens is that people say, I'm really worried that what someone's going to say I'm not going to be able to do anything about, and that it's going to be too off the scale, that I'm going to be left in a really awkward, difficult situation. And I was on a call a few months ago with Maureen, and she said, wouldn't it be interesting to look at where these conversations go? When someone says what matters to them, where does it fit? Is it difficult to do? Is it easy to do? Because we have a sense of those conversations and where they go, but we don't really know. So I put together this matrix, and you can see there are sort of 4 boxes. So simple but meaningful answers. So just say someone says, you go and speak to someone, you say what matters to them, what matters to you, and then maybe they say, oh, I'm cold, and you go and get them a blanket and some slippers, and you close the window and put the heater on. These things happen all the time, and so we thought, okay, well that's a category of conversations. The next one maybe is collaboration. So it's doable, but it takes a bit of planning. And there was an example earlier on that on the slide where there was a gentleman who he was in the hospice, and when we asked him what matters to you, he said, I don't want my wife to be told over the phone that I've died. I want her to be told face to face. And now we couldn't do that there and then, and we didn't really know how to do that. It was going to involve a conversation with the family. So the family came in and we discussed what really mattered to him, and a plan was put in place. And then when he died, his wife wasn't told over the phone because of the work they'd put in to enable that to happen. So we find that some things fall into that category where there's collaboration required, but it's pretty doable. Complex but small scale, some things fall into this. I'm thinking maybe on a ward, if you have patients who are saying my call bell's not being answered on time, maybe it's happening, it's an area that needs some improvement work maybe, and it's going to take a bit of time and a bit of energy, but it's definitely still doable. And then in the top right hand corner you can see the very complex requires blue sky thinking, and this is really where people get very nervous and they think, oh my goodness, this is going to happen, all the questions are going to be in there, answers going to be in there. But what we find really is that for patients, about 50%, just over more than 50%, it's simple and meaningful actions as a result of asking what matters, and only about 10% requires very blue sky thinking. And actually sometimes when you have something that is requires some blue sky thinking, like very complex, I've had people say to me, I don't want to die here, I want to die at home. And I remember this gentleman who said, oh, he didn't want to die, he wanted to die in the hospital, he didn't want to die at his brother's, and he was due to go to his brother's the next day. And so I was able to ask him why and have a discussion about that and find out about the fact that he travelled the world all his life and never been reliant on anybody, and he didn't want to be reliant on his brother in death. And so even though I could pass the information on, but there wasn't very much I could personally do about it. think you felt reassured having had the discussion, being able to talk about it. So that's some information and about that. And actually, we've asked staff as well. We've asked staff what matters. Maureen was alluding to the intensive, join work. And when we ask staff, it's fairly similar. Not as many simple and meaningful actions, but the data is not too different. So as Maureen showed this morning, this is the IHI framework for join work. So this is when you ask staff what matters to you, and then you do what matters for staff. And if anyone hasn't read the IHI framework for improving join work, I would highly recommend it. It's a really, really useful tool. I was involved in a project a few years ago, and we looked at had a really, really high turnover in the intensive care at the Royal Free and Barnet Hospital. And I was the project coach. It was my first coaching role. I was still a physio at this time. And we asked staff what mattered. And the staff said lots of things like, I wanted to have choice when I come to work. I'm not accessing the right training and development. I need more. I need to see my senior leaders more. I want more recognition and thanks. We need better spaces, better rest areas. And we probably did about 30 different changes. We threw so many things at this project, had a lot of senior support. And the turnover came down very, very quickly, and as it was at the end of the project was about 19%. From the start it was 42%. It was actually 48% at the Royal Free site. This is just combined data. So actually it's really important to ask staff what matters. And I think during the pandemic I was really thinking, what matters to you? And I knew it was still relevant, but how does it fit with the pandemic with staff so exhausted and tired? We'd had a join work programme that was paused because all study leave was cancelled. And so I started asking staff what matters to them. And they said, I can't get fresh fruit at the beginning of the pandemic, can't get fresh fruit, I can't get vegetables, there's too many queues in the supermarket, I'm working really long hours, I'm exhausted. So we did what mattered. I pushed trolleys around of fruit and veg, and hopefully by this photo you can see the excitement and the joy that having some fruit and veg brought these guys who hadn't seen fruit and veg for about 2 or 3 weeks. And what you can't see is what happens afterwards. The lady in the bottom right corner just goes away and actually eats the whole broccoli raw because she hadn't had any. So that's what mattered to them then. And so as a result, we set up this big supermarket for staff. We had 8 weeks of a free supermarket to support staff, because that's what mattered to them. Opened in the morning and evenings, and was staffed by volunteers, and we donated items as well to a we had donated items and items from our charity. So it was but that's because we asked what matters. And then we've done events, we've done what matters to staff days, where we've asked staff to nominate other staff members for compassion and kindness. And we opened this up, we had 3 days, we opened it up for 3 days at the Royal Free, asked people to nominate staff who'd shown a lot of compassion and kindness. We had 100 staff members who were nominated, and so the exec team went round and said thank you, and said thank you for being compassionate and kind in our organisation amongst everything else that's going on. And here's some just pictures of the day. And actually you can see here in the corner there's this is Noor, who was due to be joining us, but there's been an emergency in the intensive care which he's in charge of. So he was due to be joining us to tell us about his role and the work he's been doing. So I'm going to just quickly read out, he just sent me what he was going to say. So I'm going to read out his words to you now. So this is Noor, he's the head of nursing for critical care, anaesthetics, liver and digestive health. And I've asked him, what's it like now in ICU? He said, what matters to you has been with us for 5 years, and it's getting better every day, and we see more and more areas using it, and it's embedded in what we do. And then back in 2017, our ICU had very high turnover, and we couldn't keep our staff, and Karen and the team initiated What Matters to You in our unit, and as a result our turnover reduced from 47% to 25%. It's now 14%. And our bank usage is reduced from 31% to 26%. And the last 3 months, our agency is reduced from 23% to 7%. And so I say, how has asking what matters impacted? And he said, we've made changes based on what's come up in What Matters to You conversations. Lots of different things, the things I've mentioned before have all been changes. And what we're doing now is Nora is now not just in charge of intensive care, he's just recently taken over being in charge of the theatres. And at the moment, we're doing a big piece of work in theatres where we're asking staff what matters using a QR code. We're listening with them, we're going back to teams, having a discussion about their results and their ideas for improvement. And then we're acting on those results and making changes. And we're doing this in 3 or 4 areas now at the Royal Free, and we're hoping to expand that out completely. So that's a really, really important question for asking staff. And the other thing that we do is that asking what matters to you is great when you're trying to develop services. I know I've got at least one of our therapy partners who is on the call today. Hi, Evelyn. And basically, Therapy Partners is a group of patients and carers connected to the Royal Free that used to meet every 6 weeks in person pre-COVID. And we basically, they're patient representatives, and we have projects and we ask them what matters to you about this, or what matters to you about this change in the hospital, or what matters to you about what we're doing. And during COVID, we actually changed to remote meeting, and we met every single week. And they changed so much about what's going on in hospital, and we now meet every 2 weeks. And the scope of what they do, it was called Therapy Partners because I was a therapist when we set it up, but now the scope is the whole group. They are impacting into huge amounts of projects that are going on all over the hospital. So what matters to you is a brilliant question for them as well. So just to finish really, what matters to you is really important to ask patients, as we know, as you've heard those powerful stories this morning, but it's also a really useful, brilliant conversation to have for staff, and also thinking about what matters to your hospital and your unit, and they all go together, and we have to ask, listen, and do. So, and one last thing, my last slide is just, we really would like some feedback, and I'm going to hand over to Catherine for this bit now. We've basically designed a short sort of how-to guide. So, but just appreciating that lots of people on the call have had lots of these conversations, are experts in asking what matters to you, and would really love some feedback. So I'm going to hand over to Catherine now. Thank you.
Well, really, this is it's definitely a double act, because we kind of bounce like a little firework together off each other, as we thought, oh, we wanted to get something that we could share just as a start of a tool on all the back of like the incredible work that Karen's been talking about and has led. And from my perspective, it was about what we could use in primary care, and some of the learning that obviously Karen's already drawn out. So I suppose the request in the maybe 1 or 2 minutes that we've got, if I could ask all of you to have a look at this. So we were looking at as a tool, so just a brief overview of why you might want to do this. So I'm thinking about if we're sharing this with colleagues, and it would be a simple mini training intervention that has to be very obvious, straightforward when it's in front of you. And really just sort of put your connections down in the chat about reading, when you read the why, when you read the before, what you'd want to be able to sort of remember and think about. As Karen has emphasised, the important key part is ask, listen and do. So if I could ask you just briefly to read what's on the slide and each of the components, if there are things that you think, actually, I don't like the way that's worded, or it doesn't really make sense, or things that you've been listening to and inspired by that you think, actually, we should have added this in, but we haven't. And then also the after part is the important part, obviously, of making sure we've recorded the conversation and being able to also then reflect on our own learning. So if you could just give us your feedback. We saw this as a brief intervention to be able to get feedback and hear what people think. And thank you so much. I'll just leave it there for a minute and then pass back to Sarah. Thank you.
Thank you, Catherine, and thank you, Karen. That was a really useful session. I think particularly useful to see the data and how powerful that impact is, not just on the people we care for, but on staff as well. I mean, I thought that, 80 to 90% of staff feel that this enhances their conversations. If that was a drug, we would be dishing it out like Smarties to everybody. So it's a real a lesson to start trying to use this in our practice. Just one thing to pull out of the chat, Karen, there has been a request, well, a couple of requests about the form, the What Matters to You form that you created, and whether you'd be happy for people to pinch that with pride.
Yeah, very, very happy. Pinch away. Yeah, I'll pop it in the chat or email it round. Yeah, I'd definitely be delighted. The more people, I'm so passionate about this, the more people who have can use the tools, and we're all learning from each other. So I learned first from Maureen and from Anders, and so many people on this call I've been learning from. So we're all learning from each other. So delighted.
Thanks, Karen, and thank you for everybody for continuing to put feedback in the chat. I'm going to hand over now to Lucy Pollock and Sarah Onions. Lucy's a consultant geriatrician working in Somerset, and Sarah's a GP and specialist palliative care doctor working in Worcestershire. And this is a pre-recorded session where they talk about how they use What Matters conversations in their own clinical practice.
Hi Lucy, how are you?
Hi Sarah, I'm very well, thank you. How are you?
Oh, I'm great, thanks. I'm really excited to be talking to you today about What Matters conversations.
It's a really special opportunity, and I am so impressed and delighted that the Royal College of GPs have put on this event today. And I think there's so much that we can learn from one another, and it's a very good opportunity to share some knowledge and expertise.
Yeah, absolutely. I mean, I've been reflecting on What Matters conversations, and I guess my approach as a GP and as a palliative care doctor, and I don't know, I think it occurs to me that actually most healthcare professionals have these skills in swaves, don't they? You know, these skills to open up these sorts of conversations with our patients. But I just wonder whether we use them to sort of as a lever really for shared decision making. You know, I think we can perhaps use them better. That all sounds rubbish. Oh,
it doesn't at all sound. I don't think that at all sounds rubbish. And actually, I'm going to continue on on that question, Sarah, because actually, you're right. These can be really powerful conversations, and we're aware of their power. And when you have one of these conversations and you walk away from it and you watch a family or a patient, you watch their shoulders relax, and you suddenly realise that a burden has been lifted and that a problem has been solved, it's incredibly rewarding. But there are these big challenges in incorporating these conversations routinely into your care, focusing everything around what matters to your patient. And although people often have the skills, and I think that this audience is probably a very, very skilled audience actually, and has these very well-honed abilities, but actually there are barriers that spring up. We were going to talk about some of the things that you find in primary and palliative care that are the things that worry you when you realise that you think, oh, I should be having this conversation, but it might be the first time I've ever met this person. What are the barriers you find?
Well, I think as a GP in particular, perhaps the most challenging barrier is time, isn't it? So, you know, when you've got a really short consultation time to do everything you need to do with a patient, it's actually quite scary to open up a conversation in this way, because you really don't know where it's going to lead. But it's really interesting, isn't it? I actually find that often when I bite the bullet and I sort of take that opportunity to really explore with people what really matters, what is it about them that we need to be thinking about when we're putting together our management plan, it actually can make that conversation and that management time sort of, it can be a real lever and a step up, you know.
I completely agree with you, and I also feel it often takes less time than you think. It's very interesting how quickly you can kind of cut to the chase. So we frame our conversation perhaps around what's your understanding the situation so far. And that's, funnily enough, that's not a phrase that I tend to use. For me, saying, what have your doctors told you so far about this situation is a nice lead in. But then getting very quickly, and we spoke about this a while ago, you and I, Sarah, I love the way that you join a patient on their journey. So you have a skill where you can glance through the notes. None of us have time. You've got a moment to glance through the notes, but very quickly you see that this patient has been through a lot already. They've been in and out of hospital, or they've had a new and frightening diagnosis. And you can pick up very fast that there's something bad going on and that this is why we're having this conversation. And therefore you say to your patient, I can see that you've been having a difficult time. And I often say to mine, I say, you've been through the mangle. And my older patients recognise that. And suddenly we're in a place together where it's very like the lovely Dr. Mannix says, it is, you found out the story so far. It's such a powerful phrase. And it doesn't take long. You're quickly in there with the patient. And then you can move on to, sometimes I think, a lot of our patients have got very used to doctors and nurses telling them stuff. We're going to do this, we're going to do that. This is the plan, you're going to have this test and whatever. And there's a moment where we can stop that and say, actually, at this stage, there's been a lot going on. But the thing that actually now is most important, the most important thing, is that we understand what's important to you, what matters most to you, what you're hoping about, what you're worried about, and what you want to achieve. This is the moment for that conversation.
Yeah, and I do think you're right, the moment for having that conversation can sometimes be a barrier, can't it? Because I think as a healthcare professional, you're aware that these are sensitive conversations and you want it to be the right time. You want to know that you're the right person to have that conversation. But actually, I think, you know, the what matters conversation is really creating that that platform that allows you in, doesn't it?
And it doesn't, it's really important that actually it doesn't start at the end. It needs to start much earlier in the patient's journey. Now, obviously, my older patients often are coming towards the end, but actually, I so often feel, golly, if we'd known this a little bit sooner about them, if I had known that the most important thing was the dog, or that the most important thing was the adult child with learning disabilities who still lives with them, and their worry is who's going to look after that child when they've gone. If I'd known more about that, we would have adjusted things, changed our approach. So you're absolutely right. It is getting this conversation absolutely embedded early on in our conversations. To do that though, Sarah, we did talk also about the fact that the patient may not be ready for that conversation. So it's not just the doctor thinking, whoa, I've never met this person before, I've got 10 minutes. How am I going to do it? Am I going to get it wrong? Am I going to cause them upset? For the patient, this is a big journey as well. And I love that there are these national conversations now happening. The patient's voice is getting stronger and stronger and more knowledgeable. And making sure that the patient knows that this isn't a one-off conversation, for example. Leaving somebody say, I mean, I know in primary care you're under huge pressure to finish the conversation, 10 minutes, done and dusted, put the TEP form in the notes, you know, that you are under pressure, but also the patient needs to be able to walk away thinking, we've begun a conversation, I can change my mind, I can go away and ponder this, I can go away and talk to my family, and making it very clear that this isn't the be all and end all, this isn't now set in stone, that now we've had this, I think I understand your wishes, but I wonder whether you need to go and talk to your kids about this, or your husband or your neighbour or whoever it is that's your best friend that's going to share this with you. And that, I think, is a key thing for our patients. How do you tackle those pressing questions in primary care?
Well, it is a challenge, and it does worry you, I think, to try to sort of squeeze those sorts of questions into a very tight time slot. But I think they're a really powerful way of building trust and rapport quite quickly. You know, just allowing yourself that time to connect with your patient, for them to feel like they're being listened to, that you're interested in them as a person. And that, to me puts the patient at ease. It allows them to talk about their fears and their worries, and you know, you can move the whole consultation on so much quicker then once you know what the patient wants to achieve, what they're concerned about, and you can really build a personalised management plan that they're engaged with and they really want to work with you towards. You have a shared understanding, shared goals, and there's nothing more powerful than that, than, you know, to come away with, is there?
I couldn't agree more. And I think also sometimes we just have to take a deep breath and accept that we're going to invest some time now to save a huge amount of time and wasted resource and pain and suffering in the future. If we do the wrong thing, if we're not listening to what our patient really minds about, we end up doing all sorts of stuff that's wrong, and that's enormously resource intensive, as well as being exactly the wrong thing. And we're all here to look after our patients and do the right thing by them. So sometimes we do just have to take a deep breath and say, actually, I'm going to spend a little bit of time on this because it will save time down the line. So if time is the most pressing problem, that's the way to square it away, I think. In terms of other reasons why people feel anxious about, you know, they say, I can see the value of this conversation, I'm sure it would happen. Does it have to be me? How do you cope with that in what can be quite a fragmented primary care service? You may never have met that patient before. They may have seen several of your partners or people who work with you, or advanced care practitioners or specialist nurses, all kinds of other people. You haven't met them yet. What do you do about that feeling of why has this landed on my desk?
Well, I think it's part of the start of your consultation, isn't it? It's part of that rapport building, is just finding out how the experience of their illness is for them and what that means for the management of that. And that is how you build everything. You build on everything from there, don't you? So I think it's just not to be afraid of it. Don't be afraid. You know, you're not going to open up way more than you can take, and patients know that. I think what they want to hear is they want to know that they're being listened to, that they're being heard. And if you can't deal with it in that time frame, it's being honest with that, isn't it? But just saying that back to them, I hear that you've had a really tough time with hospital and that you don't want to go there again. We might need to talk about that a bit more you know, at another time, but let's manage the issue that you've come today with. But you can park certain things, but as long as the patient knows you've heard it, it's easy then to pick that back up at another time.
Yeah, I think we do recognise that there is a tension, as we said, that there is a perception that these have to be done in a one-off way, and sometimes they do come right, and you have the whole conversation in a 10-minute consultation. It falls into place beautifully, and you write a TEP form or a respect form together, you hand a copy to the patient, and you've got it, and it's fantastic. But it doesn't always happen like that, and sometimes these are a process. And that's fine. It isn't. Nobody will judge you if you can't quite get this conversation done in that 10 minutes. You may need to say it's going to take another time. It's hard to say that when everybody's under pressure, but these are so important, these conversations, and they save so much time in the long run that they're an investment. So I would strongly support people just saying, it's fine, I'll take the time to do this.
Yeah. And do you think in your practice that your patients are ready to have these conversations? Because I wonder about the sort of public understanding of us asking those sorts of personal questions that they may not be accustomed to.
Yes, so I'm watching my patient like a hawk all the time, and I'm reading the signs, and there is a group of patients who are absolutely not ready for this conversation, and they have, and sometimes they can be really quite frail and ill, and you think, jeepers, why have you never thought about this before? You've been living with Parkinson's disease for 10 years. Has this not crossed your mind that it might be time to have a conversation? That's fine. That is fine. If they're not ready, we just work on it, and we just gently introduce it at another time. But actually, most people are very ready for this conversation. Actually, many of my patients are longing to have this conversation. And I'm told time and again by patients or their families, they say, thank goodness that we've talked about this. It's a huge relief. So the permission to say, actually, what's happening to me do I have to go for that test? Do I have to take mum for this scan? Is it going to make a difference to her? Being allowed to ask those questions is really important, and in my experience, the vast majority of people are terribly relieved when they're given an opportunity. So I think people are more than ready. They may not have the vocabulary, and they may also not know what the rules are. I think the whole assisted dying debate has made things quite difficult for these conversations. I'm very, very keen that we improve the understanding of unassisted dying. I think we need to get that right. So giving people the permission, and I sometimes say, other people in your situation might decide that they don't want to come back into hospital, even if they've got something we could treat like pneumonia. I've got plenty of patients who say, no, that's not what I would want. So that's giving somebody permission to say, yes, I feel like that too. That's a handy way to get past those barriers.
Yeah. And as you say, I think people are relieved to open up and have those really honest conversations. I think most of the patients I deal with, they're really quite pragmatic at the end of the day. You know, they don't want to go into hospital if it's going to be of no value to them.
Yeah.
So it can actually, those conversations can be really quite surprisingly easy once you've established that initial trust and relationship, and that can be done quite quickly just by opening it up.
And I completely agree. And also, if somebody is anxious and you see that anxiety in their eyes and you're thinking they're worrying that you're about to deny them treatment, I do try to frame the whole thing about what is the right thing to do and what would you like us to do and the positive things we can do, rather than saying we're not going to attempt resuscitation, we're not going to let you go to intensive care. That's the wrong way to have these conversations. What I want to talk about is what's going to help. What's going to make a difference? How can I make you feel better? Or how can I meet your absolute number one goal which is stay at home with your cat Frankie? That's fine. And that's all about positive decisions, positive actions that are going to help you to achieve your goals.
Yeah, and I think when patients realise we're recording those important things for them that other healthcare professionals can see and have access to, to me that would feel reassuring, knowing that I don't have to keep having that conversation.
Yes,
is there for other people to see.
And but also that it is yours. So this whole conference is not just about a treatment escalation plan or an advanced care plan. This is about building everybody's care at every stage around their goals and wishes, and we need to embed that all the way. But I think as earlier in life, it's easier to make assumptions about what somebody's goals are, and those assumptions are usually correct. But later on, it is so variable what people want. I think the bit of paper, when you are having the sort of advanced care plan discussion or the treatment escalation plan, I'm increasingly getting that bit of paper out in front of the patient and showing it to them and saying, this is the form that we use. Here's what I'm going to write about you. What else would you like me to put in this box here? It says what is important to me, and showing the boxes that I'm ticking. So it's a tick box exercise, because there are boxes to tick about intensive care and IV antibiotics and so on. But if you work together and have that physical piece of paper in front of you, I think that can be a very powerful tool for the patient, because they own it. They walk out of the room with it.
And do you think that whilst a patient is watching you write down those preferences on that piece of paper, do you think they have the confidence to know that if they change their mind, that can be
Yes, that's a very good question, and you have to be explicit about that. And that having the bit of paper there doesn't work for everybody. There are some people for whom that is very definitely a step too far. But there are people who find it comforting. Absolutely saying, this is we've got to finish now, but you will want to talk to your family about this. You may want to go away and ponder this. You may want to talk to your children or to somebody, your best friend, and just make sure that you're happy with what's written on this form, because this is yours. This is what's important to you. And that is the most important thing for me, is to understand what's important for you.
So thank you to Lucy and Sarah. Lucy, I think, is on the call, so please feel free to post questions for Lucy in the chat. Just in the interests of time, because we are running a little bit late, I am going to whiz on to the next speakers, and that's Guy Perrier and Lindsey Crockett, who will introduce themselves in the video.
Good afternoon. My name is Dr. Guy Perrier. I work for the NIHR East of England Applied Research Collaboration within the palliative and end-of-life care theme. I'd like to say a big thank you to the Royal College and Marie Curie for inviting me here today, and particular thanks to Dr. Catherine Millington-Sanders and Stephen Walker for convening the What Matters Most think tank and hosting all the evening meetings we had over the lockdown period. This talk will be a whistle-stop tour about how we've been approaching advanced care planning in the East. I'll talk for a couple of minutes and then I'll pass on to my colleague, Dr. Lindsey Crockett. If there are people in the audience who would like to follow key literature that has informed our approach, I've pasted them as QR codes, so you may want to get your camera ready. I'm a trained end-of-life doula, and I'm a complete convert to their approach in facilitating what matters most conversations. These conversations are best held in informal settings, preferably over tea and cake, and guided by the form, but not dictated by the form. The first point I'd like to emphasise is that what matters most conversations are more about the process than the product. These two papers describe the need to reassess and reimagine how we conduct the conversation process. To identify and discuss meaningful details about how someone would like to complete their life according to their preferences, wishes, values and beliefs takes time. So how can a primary care team work alongside others to enable contextual factors that allow meaningful conversations to take place, and for those details to be shared amongst the person's inner support network, as well as health professionals who are responsible for their care? From a policy perspective, our work aligns with best practice guidelines in the NHS long-term plan and adopts key principles for how newly formed integrated care systems can work with people and communities. The integrated care system guidance echoes the recent Lancet Commission in that it calls for a rebalancing of the relationship between clinical services and communities they serve. The crux of the issue is adopting more of a systems thinking approach. Conceptually, the larger issues at stake are about power, trust, permission, reciprocity, and the value of experiential knowledge held in our communities. For anyone who hasn't had a chance to read this article referred to as the New Essentials, it's highly recommended. What we need to be thinking about is the chain in this image and how the interface between primary care and external partners operates. And I am emphatically not just talking about social prescribing. What we are about to hear is a short description of the Compassionate Companions project we are conducting in parts of the East. There's sadly no time to talk about how we're supporting members of the community to become conversation partners to facilitate these thinking ahead conversations. Our talk reflects the NHS quadruple aim around better outcomes, better use of resources, better experiences for patients receiving care, and better experience for staff delivering that care. And it also reflects examples of good practice from NHS England. In essence, what we are suggesting is that advanced care planning conversations are more effective and efficient if conducted by motivated and enthusiastic partners in advance of the consultation with a health practitioner. It means that when a person comes face to face with a GP or other healthcare practitioner, more time can be spent on coordinating and acting on a person's wishes as opposed to information gathering. And I'll pass on to my colleague, Lindsey, to talk about the Compassionate Companions project. Thank you.
My name is Dr. Lindsey Crockett. I'm a GP senior partner for Peninsula Practice in Suffolk, covering a very rural population of about 7,000. But I'm also the clinical lead for end-of-life care for Ipswich and East Suffolk CCG as it stands currently. I'm really honoured and thank you so much for inviting me to talk with you because there is a need in end-of-life care services that GPs cannot provide alone. So how do you do a good death in 10 minutes, literally? Well, a GP can't, not alone. We are stacked, aren't we? Our workload is intense and it's become more so in this recent time. But we are realising that there is a gap in care for those people at the end of life who don't need the clinical provision that we are trained to be able to provide. But if we don't work in teams together, then we're going to fail our patients, and that doesn't feel right, let alone appropriate for them and their families. And of course, the care that we offer to our patients out there is also the care that we can expect for ourselves and our own families nationally. I call it emigrating. I emigrated from London to this beautiful part of England. I'm just looking outside the window to see sunshine dappling through the trees and there's no traffic. It's very countrified. And with that comes its own complexities of medicine. We have a lot of elderly patients who do not want to go even to town, let alone to hospital. And the majority of patients nationwide express a wish to die at home. But when I came here, I felt responsible for ensuring that that was provided for. And it took me years to realise that I was conflicted in not being able to provide that care and what that felt like. And then recognise that who am I to think that that's possible to do it on my own? And that just because we do have excellent community support from our healthcare professionals, our district nurses, and excellent hospice support, it wasn't everything that patients needed. They needed additional care as well. And the care that they needed was non-medical, compassionate support. And the compassionate support would also help us deliver the service. So it's not possible to have a conversation with a patient over the phone who we might not have met and find out their resuscitation wishes or even their understanding. It's not appropriate to pick up the phone and talk to them about would they like to go to hospital with their chest infection that we might also have to be deciding how to treat. So how is it appropriate? We also can't make home visits and sit for the half an hour or hours with patients and their families to find out what their end-of-life choices are. They might not even know what their end-of-life choices are. So in 2017, I called a meeting for people who live locally in their communities and some of the voluntary organisations, and we sat in a very cold village hall room and shared experiences, personal experiences of the gaps in care as people saw them. And through that evening, I recognised there was a theme showing us the gaps in provision of care for people at the end of life. And those themes were particularly around time. Time for conversations, time for people to understand what the choices are at the end of life. Some people didn't even recognise that resuscitation was something that they can be included in the discussion of. Some people thought resuscitation was automatic. Some people didn't realise that if they don't discuss their funeral choices, they might not be honoured. People didn't recognise that if the doctor doesn't know what their wishes are, they might be sent to hospital against their wishes. During that meeting, we also heard how compassion was embedded in our communities, and it wasn't compassion that we were trying to train up. In fact, I was told very clearly from one of our wonderful Good Neighbours scheme leads, Lindsey, they do not need training in compassion. The compassion is there. It's just a little confidence that we all need. And that taught me one of the greatest lessons of my career, that it's about recognising and harnessing the power in our communities. So together we developed a proof of concept, it turned out to be, rather than a project at that point. We were lucky enough to get some funding, and a number of volunteers living locally in their own communities were trained by the Living Well, Dying Well team together with End of Life Doula UK. And they did the foundation part of the doula course. And with that training, they were empowered with confidence and competence to befriend patients at the end of their lives and to support them and their families. And what our companions do is literally just befriend. They go around and have a cup of tea, or they go out and walk the dog with the patients. They develop relationships whereby the patients can call their companions and have a chat. This is all very non-medical. There's some very clear boundaries for the companions that they're not responsible for any medical or nursing or personal care needs. And the companions also have direct contacts with the administrator who coordinates the companions and their meetings with patients, but also the clinical coordinator. So what happens? Well, during the initial proof of concept project, I would identify patients at the end of life. I would match them with our companions that were available, particularly if they lived in the same community, because this is about mobilizing the community. One day it would be dreamy to think that we don't have a label of compassionate companion or good neighbours, that we all just reclaim what we know how to do, which is to support each other in birth, in life and in death. So I would match a patient with a companion. I would go and visit the patient and introduce the companion, and from there a mutual agreement in terms of when shall we next meet, when would you like me to come, and those relationships developed. There were no rules other than the governance of safeguarding. Of course, DBS checks were done, and we didn't encourage our companions to give their personal phone numbers, but some did, and some didn't. And this has been really successful enough that we've been lucky to get some further funding to roll out this project across Ipswich and East Suffolk. We're recruiting more companions from different communities, and End of Life Doula UK and myself have developed some bespoke NHS training for these companions. We've recruited a clinical coordinator and an administrator, and together over this year we will further develop and hopefully progress the concept. And what this then means is our companions can liaise with our clinical teams and make it easier for us to be able to have conversations with patients when the seed has already been planted, when the conversations and the choices have already been made. I would just like to share with you one slide or two slides. This is a beautiful daisy drawn by Paddy, one of our patients who is still with us, and an absolute advocate for the companion scheme. But on the second page is perhaps more informative. This is a Health Watch survey carried out last July, asking families about aspects of care. And if we just have a look at these circles, what we want is a completely 360-degree blue circle, which tells us that all or most of the time, things like adequate pain relief, helping managing symptoms, etc., were provided for. But when it comes to the companion side of things, we're recognizing that being involved in decisions, wishes are taken into account when they're asked what's important to them, and their emotional support, we're not quite there. We're not that bad, but we really do want to complete that blue circle and make it, virtually 100% that people do have their wishes honoured. People do make choices that suit themselves, as opposed to fitting in with the medical model that's available. This also has a positive impact on the families who are left grieving. One of our patients, who has had a companion for some years now, she has ovarian cancer and it's slowly progressive. For 2-3 years, between myself, my team, our community teams, because she has regular district nursing, and the hospice is involved and visits regularly, we have all attempted to just open that door to those conversations about end of life. And it has been very quickly closed by our patient. She has not wanted to hear, not wanted to know. She has almost sensed, I know where this is going and I'm not ready to die. And yet we've all seen progressive disease, and we're all recognizing that we are almost certain that she doesn't want to go to hospital, that resuscitation would be futile. But none of us were quite ready or able to, or wanted to disrespect her in forcing her to have these conversations. Until one day, literally 3 weeks ago, and her companion rang me and said, Lindsey, we've just had a conversation that she led and wanted to get on and do the paperwork. And by that, she meant the resuscitation, DNAR form, and look at advanced decisions to refuse treatment. So I thought, right, this is the time. I rang her thinking that we were going to have a really long conversation. And literally within 5 minutes, I had completed the DNA form. And it wasn't rushed, because she said to me, Dr. Crockett, I've spoken with Chris, and I am very clear, I don't want to go to hospital, and I didn't realise that if resuscitation is attempted and successful, I will have to go to hospital, and then I'll probably have to go to a nursing home because I can't carry on living on my own, and I don't want that. I'm not going anywhere. It was so clear, and it was so humbling and beautiful to have that conversation with her, knowing that the person who enabled that was her companion through a growing, trustful relationship, and then was able to make her safe enough to be able to explore the reality which is imminent. So I hope I've been able to share with you one way that we as GPs can be supported in supporting our patients in end-of-life care. The companion model is not unique to us. It is used in other ways across the country and called different things. But we feel that with a bit of training and supervision and support, we can facilitate companions who are volunteers living within their communities to empower their own communities. And there we can learn from our communities what the needs are. And I think that's, you know, a beautiful way to care. Thank you for having me.
So in summary, we are suggesting that preparing for a time-constrained clinical consultation is key to delivering personalised medicine in this context. The process of having a what matters most conversation is more important than the product, as it should enable a person's inner support network to advocate on their behalf, which has been referred to as a form of relational autonomy. Primary care practices should consider how they interface with their community beyond attempts linked to social prescribing. The most important shift that needs to take place is to introduce a capacity for shared learning and a sense of collective growth, as opposed to improvements in healthcare transactions. This model from Etienne and Beverly Wenger and the Health Foundation encapsulates so much of how and where we need to move. The QR code will take you to a resource they have described as systems convening, but this model you're looking at right now has a lot of promise. And lastly, if you wanted some ideas for conversation starters and points of discussion, I can recommend this resource from Leaving Gracefully. And finally, if anyone would like further details about anything Lindsey and I have discussed, please drop me a line on this address. Many thanks for listening.
So a huge thank you to Karen, Sarah, Lucy, Guy and Lindsey. I think we've got caught in the trap in medical profession sometimes of calling these conversations advanced care planning conversations, when actually that makes them sound complicated and they needn't be. These conversations can be simple, what matters most conversations, 4 little words that, as Karen and Sarah have highlighted, are the ticket or the key to get you in the door, and that investment in time can make a real difference for patients.